Let's go ahead and get started with our next session. Chris Metzger and Peter Soukas will be co-moderating this esteemed panel up here. And so the format, again, is a case presentation by a master. It'll be about 8 minutes of the case, 7 minutes of discussion. Most of them are very expert at telling us when they want us to ask a question or when you want to stop. So Tony, do that as needed. Otherwise, we'll interject and make this very interactive. So without further ado, I'd love to introduce my good friend Tony Das, who uses all these devices, but he's going to show us a laser case in an interactive fashion. Tony.
All right, thank you, Chris, and thank you for the invitation. So, you know, laser's been around for a really long time, and now there's new devices that exist. The question is laser still relevant in peripheral arterial disease management? And the answer I'm going to try to explain is yes. These are my disclosures, none of which are really relevant to this particular presentation. So this is really what you need to learn about laser, which is that it's really the laser physics that allows you to use this in the most efficable way in the cases, knowing that it's going to have the ability to dissolve bonds, knowing that there's some energy created, and knowing that there's photomechanical actions allows you to pick the type of laser and exactly what you're going to do with it in the types of lesions that we're going to address. There are now two commercially available lasers that we pick between, and you heard a little bit about each of these this morning. There's slight differences, but some of them may be important. The wavelength of the lasers is how it reacts with tissue, and Philips at 308 nanometers and the Orion at 355. The pulse length, longer versus shorter, fluency, and the way that the gases are in the Philips laser, and there's a solid state system in the Orion. And aspiration is available for the technology that's under the Orion. So just to understand a little bit about the differences. So where do I think that laser makes sense? I actually think that these are the 4 or 5 types of cases where laser makes a difference. One is compliance change. We talked a lot about compliance with atherectomy. This is just another form of atherectomy that sort of uncovers lesions. Uncovering lesions in diffuse disease is an important part of what laser does because of its direct effect on thrombus and addressing platelets in these lesions. Places where there is no stent zones, I think we want to try to get as much change in the compliance or try to avoid dissection, and certainly ISR approval for laser for in-stent restenosis and the direct platelet effect for thrombotic disease. Places where you would not generally think of atherectomy, laser atherectomy and thrombotic disease is actually quite helpful because of its direct action on thrombus, and platelet aggregation is reduced by the deployment of laser, and at higher energies it actually does a better job. So let's talk about a case of, we saw one this morning where atherectomy was used in the last live case around the arch or down in the foot, and people were worried about distal embolization. So I'm going to show you a case where we used an Orion laser even further down than that. This is a lady who came to us with a diabetic foot ulcer. She had ulcer started about 6 weeks prior. She didn't really have much pain at first, and then it became constant when she came in. This is what was seen. It didn't look like much. It had already been debrided by the podiatrist. They, of course, did a plain film and showed erosive disease, and you can see the distal phalanx of the right first and second toe are absolutely missing, so we've got osteomyelitis involved here. So we know that even though superficially it doesn't look like a severe wound, there is already damage to the bone at this point. And you can see completely flat toe pressures bilaterally as you get further into the foot, and it was monophasic flow below the knee. And an outside angiogram was performed and sent to us as, quote, normal 3-vessel runoff. And this was a single image from that angiogram, which at first look kind of looks like 3-vessel runoff, right? But what's missing here?
The arch in the foot.
The foot, right? So when in doubt, go down and take a look at the foot. So we got the patient, did a left femoral access, went up and over our usual techniques for doing this, and then ended up with a command wire into the occlusive disease, but couldn't cross with any balloons. And so I'm going to just set the case up to ask you what you would do next. Here's the proximal vessel, not too bad. A little bit of diffuse disease in the distal popliteal vessels, but rapid flow until the TP trunk. And they were right. There really is 3-vessel runoff, but it doesn't make it to the wound. So the question is now, what do? You've got to look a little further. And so the next injection is looking at the pedal arch, which is really kind of the culprit problem. You look around the arch and you see the posterior tibial doesn't make it around, the anterior tibial doesn't make it around. So this wound is not revascularized, even though on quick look, it looks like it's probably enough. So are we going to stop at this point?
So Tarek, let me ask you before we start. You knew that the angiograms were pretty normal to the mid-tibials.
Yeah.
And you've got an ulcer. Why contralateral rather than antegrade in that? Just because you were doing a diagnostic picture first? And you didn't want to go antegrade for diagnostic, or why wouldn't you go? Or is she incredibly short, or why?
She's short, and contralateral is my usual technique anyway. And now, with as many devices that we have that are longer, right? We've got 200 centimeter long balloons. We can get around the pedal arch even in relatively tall patients. And for all the usual reasons about access and complications, et cetera, I like the contralateral approach for most of these people, unless they prove to me that they're not great candidates for it. So she is relatively short though too, so it does help. So this is the angiogram now with a foot, and so the question is, now what? All right, so gives it a second, and you see down the posterior tibial relatively far, and you can see this injection is all the way in the posterior tibial. Like Chris, you were saying earlier, you can't really get a great feel for what you're going to be able to fix or not fix until you get a selective angiogram. So now there's a catheter in that territory, and now we know that there's potentially an option here. So now we bring down a wire and do a roadmap image and put it into the posterior tibial. The patient decides to move their foot right at the wrong time. But nonetheless, we're able to get down into that distal portion of the posterior tibial, and then we kind of run into a stop right here, right? It's not going because it's occlusive, so try to bring down a catheter. What do you want to do next?
What wire is that?
It's a command wire. Yeah. Command ES, we're at the foot, we're not around the arch yet, but I have pretty good visualization of that there could be an arch here. Anything else?
And will your quick cross go, is it a 150 and it will go beyond the ankle to give you more support, or is that the end of your rope?
So this is where the problems start to begin, right? So here I'm unable to really get things to go further. I'm able to get them to this point, but I can't get the catheter to go much further than this. But of course, once you have a wire across, that's where laser is so helpful, because you don't lose wire position and you don't have to change the wire to do atherectomy of any other type. So ultimately we got it to here, and then I was able to cross around the pedal arch in a loop technique and go back up, and you can see that the catheter won't go any further. This is as far as it'll go. And the catheter won't go any further, so well, let me take a balloon and see if I can make it go around. The balloon won't go any further, so now we're stuck. So I've got a wire, I've able to retrograde cross the anterior tibial, feel like we could have some success here, but nothing's going to follow. So do you abort the case? Do you use something else? So what now? You can keep using shorter and shorter balloons, try that, but you're starting to run out of room a little bit. So
let's hear some of the panelists. You want to snare that and use one of those, like a sublime balloon that's got a long shaft? What are some other thoughts here, Lawrence?
No, this is a challenge no matter what. Even if you got, like a CTO catheter, like an Echelon or Turnpike down there, you still need to do something, and it's the crossing. So small balloons and then escalating them up is probably a good start, but then you're going to have to do something else. And I was just going to go back to this incomplete arch. I mean, the Olive 1 and 2 and 3 is out of Japan really showed that if you do get this completed arch, to your point, you heal wounds better than if you have the incompleted arch. So Tony, what did you end up doing?
let's see what Sameh would do real quick.
So the other two possibilities is, one, what if you're able to snare this wire and switch to a very long wire, and now you have both end of the wire outside the body, so that can give you more ability to kind of deliver things. And the second, you can try, again, this is up and over, so you're not gonna have that privilege, but if you have an antegrade, maybe some of the shorter coronary balloon, rapid exchange balloon can sometimes get you to run that. That's that sharp bend what you're getting you, what that difficulty is.
Yeah, so it's kind of counterintuitive to think about atherectomy at this stage, because if you think about it, if you can't get a balloon, like the last thing I want to do is create a perforation or a problem down here. But one of the things that we've experienced is, as we've moved from using both of these laser devices, that in the Pathfinder registry, we were able to get this 0.9 Orion laser around really complicated. This is actually we did in the trial. So you can see it was a patient that has no ability for the catheter to go any further. The wire's gone up, and so balloons don't cross, nothing else seems to cross. So look at this image right here, and you can see now this laser moving from the first arrow to the second arrow all the way around that angle. So just changing the compliance is a game changer for being able to get a balloon down there. And it's interesting because part of showing this case is to be able to say, you know, John Ite and I were talking about would you have used CSI in the last case and questions about distal embolization. And it's always good to see, are there places where you can push the envelope safely, and are there devices that reduce the risk of embolization, perforation, et cetera. And I think that laser, particularly this particular one, it hugs the wire so closely, but it does give you a channel. I couldn't get anything else to make that turn. So after doing this, it really didn't take a whole lot more to then bring balloons down. And you can see that the laser channel that's created, again, to Subhash's point earlier, are we trying to get a big lumen, or are we just trying to change compliance? Well, did we get a big lumen? Not really. It's bigger than 0.9, but it's not much bigger than that. However, you can start to see the connection between the two sides pretty well. So now it's a matter of, can you get balloons down there? And sure enough, a 2.5 and a 3.0 balloon at the arch. Now, would you have used a 3.0 balloon around this arch after having seen what the image looked like? Come on, you guys. 2, 2.5, 1.5, 1.0.
Just call me skittish. I always start with low and then build.
Yeah.
It's like a haircut.
Well, I agree with you, but I think that one of the things that we know about tibial vessels is they're way bigger than we think they are. And even around this, when I looked at, if you go back one image and you see what the distal vessel looked like on the arch there, it was relatively big compared to what, let's see here, I'm going to just go forward and just show you this one picture here. As the image, so look right at the dorsalis pedis portion, it looks pretty big. So to me, I'm looking at that distal portion saying that's about a 3.0 vessel. So I did start with a 2.5, but look how easily, not without any pushing, but now you're able to get not just short balloons, but relatively long balloons up, over, and around, and then balloon dilate that territory. And then you can see that the patient ends up with pretty good flow, a little bit of spasm distal to where the balloon site was, a little nitro improves that some, and ultimately that toe ends up healing. And I think with the final angiogram suggesting that it's open and you've got such good blush, we stopped. But to really conclude is that laser is super relevant because it does things to the vessel that other devices don't. And the one big thing that it does, I think, is it uncovers disease, particularly in thrombotic and occlusive long segments where you can tell where the actual lesions are. In several of the laser trials, what was learned was that you could reduce the amount of stenting that was required by doing this uncovering. And in addition to that, there's areas where following very difficult wire crossing, you don't want to lose the wire. It's the only device that you don't have to change the wire for. So we do, in that situation, understanding that it's dissolving molecular bonds, it's changing the way that the compliance acts, and it's creating kinetic energy and ultimately allowing you to be successful. So thank you very much. If there's more discussion, we can do that.
Great. So real quick before we go on to the next, that's a great case study, an amazing result. It looked like DVA kind of stuff. But Nick, you use this Arian laser line. Anything different about that that lets you do it compared to the other? Where would you use this where you didn't use other?
Yeah, this is a great question. You know, I mean, the Orion, we've been quite impressed with it, to be honest. We've been using it. I have over 150 cases done with the Orion. And I can tell you the 355 nanometer is uniquely suited for these small vessels. I mean, you don't have deep thermal injury. We've done IVUS analysis on both above the knee as well as below the knee. The rate of dissection is extremely small. Distal embolization is almost nearly non-existent. So use a filter. I don't even use filter anymore with the Orion at all. I think the more important thing, if you look at the layers of the vessel by IVUS, you're not really creating any deeper dissections into the adventitia. We have the 1-year data for the Orion below the knee is going to be presented soon, so I don't have the leverage of mentioning that to you other than to tell you it's been good.
Tony, can I ask you a question? So is the is the change in the nanometer wavelength critical to engaging calcium in this catheter as opposed to this, what we all grew up with, which was spectronetics?
Yeah, so
208?
scientifically it is, right? So if you look at, and thrombus is also a little bit more, so if you look at that spectrophotometric wavelength that we've seen for with thrombus, at 308 really gets a pretty good job. 355 actually does an even better job. So calcium is, and it's just short pulse waves too, right? So the quick and small microcavitation bubbles that you're getting are going to affect the calcium differently. So theoretically, there is an advantage for this wavelength. And you know, we've all done some cases with this device, and in the trial we did a fair number, but you know, we have 20 years of experience with the other laser, and we learned a lot about what it can do. So we're just trying to get the nuance down. But I do think it changes.
Tony, you have so much experience with laser, but I'll ask a contrarian question, probably in the minds of many who are not as experienced. So the ability of the laser to cross this very angulated lesion, in your opinion, what you said, is a combination of both its profile and its forward ablation. Now, is there a risk of this catheter actually sitting against a 360-degree turn and ablating not the lumen, but the wall? And I think someone who is starting with this or relatively new may have those concerns.
Sure.
Now, what did you do technically to avoid it, and or were you anticipating it, and what was your bailout strategy?
So great questions. I mean, I think one of the things that we frequently have to think about is what is the device that you're using doing at the tissue level, right? So I know that if I'm advancing it and it's not going, I need to let the catheter do its work. How does it do its work? It creates these microcavitation bubbles, and it explodes those bubbles in a way that allows the mechanical energy to sort of move it forward. If I'm encountering a lot of resistance, I'm not going to keep pushing. What I'm doing is I'm allowing the bubbles to expand and contract. This wavelength allows those bubbles to be very interactive with the plaque that I'm running into, and ultimately allows me to almost glide around this. On the other hand, if I was running into a lot of resistance, I might increase the fluence, the millijoules per millimeter squared, which is the energy density, so that location, but without pushing, right? So it's a matter of when you have the right tool, you end up with success. If you push the right tool the wrong way, you're going to end up with failure. So there was, the only strategy I really had to bail out if I wasn't, is to try to not get myself into the problematic situation where I was creating something that was because I was pushing too hard.
So Tony, so you had a lot of experience, a lot of patient, a lot of physician has not used this device yet. If you want to give someone an advice, just number one, the best way of treating it, the best wire to use it over, and what should be their first 20 cases to get comfortable with this device? What would you recommend?
Yeah, I mean, I think with any device, the key is to use it in places where you don't have to use it. It's an alternative in certain situations, just to get used to how it's going to behave in different spots. So an in-stent restenosis segment, if you're looking for trying to feel how the ability to push, what the resistance is going to be like, moderately calcified, not severely overly calcified. So start with trying to understand what kind of the mechanisms are. I always used to say when new devices came out, I'd try to use them 50 times to determine on either side of what was in the middle of the fairway what you could actually do with them. And I would suggest the same thing here, is use the device enough in places where it's not your only choice to be able to figure out what it's going to be able to do. So clearly this wouldn't be your first 50 cases, or maybe not your first 25, but diffuse disease, knowing that your wire's in a good position distally, in-stent restenosis, a thrombotic lesion with the aspiration capabilities, all of those are fair game. And I think that get used to what the device does with those cases, and then come to something like this when you have to.
All right, I think we'll move on to the next case. Tony, that was a terrific example, a great result. Congratulations. We're going to ask Sameh Sayfo to come up and give us a talk on orbital atherectomy. It's really a pleasure for me to introduce Sameh. We had the great pleasure and honor of having Sameh join us up in Providence at Brown for his interventional fellowship, and he's obviously gone on to do great things and is now the endovascular fellowship program director at Baylor Scott & White in Plano. So Sameh, I know you're going to show us something impressive. Thank you.
Well, thank you for having me. And as Dr. Banerjee said, if you want to present something that's controversial so you can create discussions. It's very humbling for me to present orbital atherectomy among a panelist who basically staged the whole learning curve for us to do orbital atherectomy. And some of the papers I'm going to show, some of the panelists actually were the first authors or on the author committee, on the authors. So this is just to try to summarize the most important data points we have so far, or data we have so far on orbital atherectomy. I think orbital atherectomy has been and still the most used atherectomy device in the country. If you look at the data, this just I tried to select some of the most important trials. And if you look at, for example, Compliance 360 or Calcium 360, for the Compliance 360, what it showed is this reduced the bailout stenting, which was very important, and of course the higher freedom for TLR in 6 months. And if you look at, for example, Liberty 360, that has data for 3 years that has significant higher freedom of major amputation. And one of the interesting part about the CSI, for someone like me who's interested in radial to peripheral, they were the first atherectomy company, the first company to create an atherectomy device for radial. And there was a paper called REACH PVI that basically studied that concept, and they looked at prospective observational single-arm multi-center trial, and they did 50 patients, and the success rate for this method was 98%. And there was no significant or serious disembolization, serious thrombus formation, or serious side effect. I think everybody who used the device always worry about disembolization. There's a recent paper from Japan, that's the Kaizen study. So I'm going to have 4 cases to show you. I'm going to go through them and create some discussion. So 70-year-old male, severe claudication of the right leg, BMI 50, that's our average in Texas. A previous history of AAA, so that gives us a limitation of what access option we have. And if you look at the angiogram, you have this discrete, heavily calcified, eccentric lesion, maybe a nodule. And in this situation, that was one of our earliest adaptation of the technology. And we did a no-filter CSI, Diamondback, and then we balloon angioplasty with DCB, and that's our final result. Less than 30% residual. Actually, we put a stent in this case. There we go. It was less than 30% residual. So the moment we get comfortable with the device, we start using it in more complicated cases. So 83-year-old male, previous SFA intervention with IVL and draconic balloon. He came back with another SFA occlusion. Heavily calcified, really nasty looking lesion. In this situation, the only long microcatheter we had was the Viper catheter, which I highly do not recommend using in radial to peripheral. Now we have a longer catheter, like a Sublime catheter, and the Navicross will be coming online very soon. But we're able to get with the 035 crossing, and then we did a Viper wire, and we delivered a CSI, and you can see significant flow limiting dissection. When we did this case, unfortunately, we did not have the privilege of having a 200 shaft DCB. So in this case, I had to put a stent. So we deployed a 7x150 Masiago stent, and that's our final result. This is a 65-year-old female. I'm just going to go through all the cases, just different type of cases would be used, and we can open for discussion. So 65-year-old female, severe claudication, had a pelvic radiation for uterine cancer. She used to live in Arkansas. She was referred for a bilateral common femoral artery stenosis, and she appropriately received a gold standard of care, which is surgery. Unfortunately, she had an infection and a cyclic lymphedema that lasted for 6 months. When she moved to Dallas, she came to see me for her left leg, and her first word was, I don't want surgery. So if you look at it, we did an angiogram transradially in this patient. Again, I want to access the groin that just healed. And you can see a severely calcified eccentric lesion in the common femoral. You see the IVUS picture up there. And we did a Diamondback followed by DCB, and that's our final result. And very important to make sure you protect your profunda. This is another example from more complex.
Hey, do me a favor, Sam. Go back to that last one. In the spirit of the interactive nature of this, tell us what you used. Was that a 2.0 Diamondback, and did you use a filter? And you had IVUS. Was 6.0 big enough for the common femoral artery?
Yeah. So this is a great question. So this is a shorter patient. So we're able to use an embossed over the bare wire 300, and we're able to do a diamond back, like the traditional to solid in this case. And DCB, we have a 6x40. I think the IVIS, I'm not sure if you can see it, it's behind my screen. It was around 6 millimeter of vessel, but as we learned from a common femoral, usually they are bigger than what we think they are.
Okay, sorry.
So another case, a 75-year-old, history of PAD, had a left iliac occlusion. He received a fem-fem bypass 10 years ago, then that failed 4 years ago and had a redo surgery. So you can think about how hostile that groin is. And he comes in with basically a life-limiting claudication, reservoir 3. We've sent him through a walk-in exercise. He failed it he couldn't complete it. ABI was 0.4 on the right, 0.92 on the left. And the CTA showed an ostial SFA, distal common femoral occlusion, and open fem-fem bypass. So this is when we went transradial access, angiogram. You can see this discrete, very tight occlusion. This was maybe 6 months to our fellow's training days, so she really wanted to try to cross it, and she really did a phenomenal work. But in this situation, what we end up doing, we put our Terumo sheath around 119. We're a big fan of the 018 command wire, and she was able to cross it very nicely. And we couldn't even deliver our Navicross, the 018, so we had to pre-dial with a balloon, a 2.0 balloon, and then we swiped to a Viper wire. And in this way, we tried to kind of do a diamond back CSI, but we need to be very careful with the takeoff of that fem-fem, because we really don't want to damage the fem-fem bypass in this scenario, because the left leg is dependent on this fem-fem. We use IVIS aggressively to make sure we mark it, and we know exactly where we're going to treat it. And we end up doing an angioplasty and actually IVL in this case as well, and followed by 7x100 DCB. And we had a less than 20% residual. We did a gradient across it, and there was less than 5 millimeter gradient. And this is our final result. You see a nice profunda that we didn't see before. So this is just a quick R2P toolbox. I mean, this is just growing every day. A lot of companies now growing that field, trying to get us product that we really need that we don't have. We have it in the femoral access. We don't have it in the transradial access. So, but this is, if you really want to open that project in your lab, you can't just use the product that you have. So from access side, the crossing devices, then the long wire, the long microcatheter, to the treatment, as I said, atherectomy, CSI, and diamond back were the first atherectomy available. Now we have the Ariane laser. From angioplasty, we have 3 different companies with different balloons. So it's really important to have those products before you start tackling. This is just examples of those products. So key learning before we finish is orbital atherectomy can be used via radial or femoral. There's a limitation, and you just need to have the right length and the right size. The adjunctive therapy, including IVL, serenator balloon, or scoring balloon, is important in those cases, because as we saw in the last case, the live case, just a CSI or diamond back by itself is not enough. You need to have something else to expand that vessel. And a recommendation, if you look at all the trials, the recommendation is to do 2 passes per speed. Even if you look at the reality trial comparing diamond back to hog, that's what they recommended. So I think this is one thing we should encourage our operator to do, is just doing 1 pass with a low run may not be enough to really debulk that calcium. Thank you.
Any questions from the panel there? Nice job, Sam. A lot of experience with the Orbital. Any thoughts or questions, or we should go on to the next case? Go ahead, Subhash.
So Dr. Banerjee is asking, how do you pre-plan for these cases? And I think the worst thing that can happen is to do a complex case ad hoc. That's how complication happen, and it's important. So all these patients get an ABR ultrasound, and unless the creatinine is elevated, we actually CT every patient. And I think the CT, even though this is controversial, should you do it on every case or not, we do it just because it helps us planning, especially from a radial perspective. And so that's how we plan it. And sometimes if I don't have the anatomy, let's say patient transfer from somewhere else, I usually go transradial just to take pictures, just diagnostically. That doesn't mean I'm going to do radial every single case. I think it's very important to know the limitation of radial. I mean, I think I'm a very big fan of radial, but I do a lot of femoral access as well if the case required. So CT helps. Just diagnostic angiogram to have a plan before you open those products is extremely important.
Thanks, Sam. We've got one last question on this. Tony and Peter, you use both CSI and IVL a lot. So we got two therapies now. In a briefly, what would you say would be the scenarios that would tell you, hey, I'm going to use orbital atherectomy versus IVL? Go ahead, Peter, you want to start, and then Tony?
We actually published a paper on this very subject a couple years ago in CRM, and when IVL first became commercially available, we had always been using atherectomy as our typical vessel prep strategy. And so we had a lot of cases initially where we would start with atherectomy, most often, in fact, orbital, followed by IVL, and then when DCBs became commercially available, follow that up with a DCB to try to get a good long-term result. And what we found was that, especially when we did serial IVUS imaging, was that the actual luminal gain from the atherectomy was really quite modest. And so we sort of evolved into a strategy where we just basically went directly to IVL followed by DCB, and we didn't really seem to have any drop-off in terms of our patency rates. Now, having said that, I still think there are cases where we will do all three, where we'll do combination therapy. So for the really exophytic, subtotally occluded lesions, we usually like to make a channel with orbital typically, followed by IVL and DCB, particularly for those areas where we really don't want to put a stent in. So for example, common femoral and for popliteal. So I still think there's a role actually for all three to be utilized in those particular case scenarios.
Tony, anything else on that?
Yeah, it sounds like Peter's got a lot more money at his institution than maybe most of us do, so that's always good to know. If I need to borrow some, I'll come up there. But I think the point that you make is that sometimes you can't get away with just one, and I think that's really what we have learned, is that if you can't get a decent pre-dilatation, the shockwave will give you a good one, but without changing the compliance, you may not get the best result from the shockwave IVL. So part of what you're saying is that there are certain anatomic appearances where there's lots of exophytic calcium that you have to change what that compliance is going to be to even get the IVL to work properly, because there's plenty of times when you use IVL and you have what I would call an average result, and there's other times you use it and it looks phenomenal, and part of that I think is based on how it's been pre-treated, whether that was with a balloon, if it was able to be changed by compliance of the balloon, or by orbital atherectomy, which is typically what we would use in these situations.
Lawrence, I think we're going to go to you next because of case loading, so I'll have you go ahead and join us up there and I'll introduce, I will say in the lumen size, to your point though, if I'm going common femoral iliac, I think the IVL gives you a much, much bigger lumen with less dysluminalization, perhaps. All right, so our next speaker, I think we're going to change orders while the other case is getting uploaded, so it's my honor to introduce a good friend, Lawrence Garcia, who's been in the space with directional atherectomy probably since its beginning, both as an operator and experienced trialist, running a lot of the trials, talking on this. So Lawrence, we really look forward to seeing what case you have for us with directional atherectomy.
Thanks, Chris. I'm not sure if that just means that we're old, because I think it is. We're just getting too gray for all of this. If you can load up my slides.
Not as gray as me, pal.
That's crazy talk?
Let's go ahead and get his slides up for him, please, Dr. Garcia.
If it's any indication, Peter, of crazy talk, here come the glasses that will allow me to see what I'm about to talk about. So I think at the end of this last discussion, which I think is so critical, when we talk about all these devices, they're one, and I'll show you some couple cases, one complication in a case, and then go through the data. As you know, I'm really focused on having you understand the data behind what we do. But the key element is it's not a one and done deal. We're never going to have this one, kind of panacea group technology which allows us to do everything, and that's why these different devices are around. Let's see, this thing doesn't want to go forward. I'm hitting the forward button. There it is. These are all of my disclosures. They're the same for every trial talk I ever give. As said, I've been in the space for a long time and led many of the trials. First case is a calcific long SFA with fairly diffuse calcium. Nobody would argue that this is not a long lesion. There is a singular picture of the device to the right and the calcific nature of this, and there's a balloon in there, a quick cross behind crossing. And then this is the final result following directional atherectomy and DCB. Again, a very pleasing result. I'll show you a case that went into the reality trial, heavily calcified artery with a subtotal occlusion at the top end of it. And here's a great example of, I still call it Silverhawk, but Fox Hollow, but here's on the left you saw how that, let's see if I can go back, how that device got a little bit proud, as we say. See when it starts to bow out and the nose cone does not go forward? That spinner that cuts the atheroma is about 0.3 millimeters to 0.2 millimeters, but as it gets proud, it bows out further. And the next picture just shows you this kind of deep wall cut, which is in essence a dissection. This is adventitial staining. In the coronaries, this is the risk of acute occlusion. But in the spirit of the trial, we went ahead and did the DCB part of it, and the guy had his follow-up ultrasound. And I am proud to say that we were the one case that had the pseudoaneurysm in reality, and there it is. And following this, we put in a covered stent, and you can see the final results there with a nice exclusion of that pseudoaneurysm. This is one of the first cases we did at the Beth Israel years ago for a patient of mine with diabetes and an ulcer. And this shows you kind of distal popliteal into the trifurcation, into the posterior tibial, using the Silverhawk device back then, showing a nice pleasing angiographic result. But what we're talking about here is like everything in peripheral vascular disease, even in coronary disease, is calcium is everywhere. It is ubiquitous in our patient population. It's the way that your body deals with it. In atheroma, it develops calcific disease. That calcific disease is an impediment to not only stent deployment when it comes to coronary disease, but it's also critical when it comes to DCB delivery. And this is the classic Finelli paper showing that. So this is dated data. This is old data when it comes to definitive LE. It's about 12 years old now. Jim McKenzie, myself, and Tomas Zeller led this trial. And I focused really, since this is really looking at critical limb ischemia, I blacked out or grayed out the claudicant group, but 200 patients in CLI with the demographics is listed here. The patients that got enrolled, Rutherford class 3, mostly in the claudicant group, but Rutherford 5 was principal what we saw in the CLI group. When it comes to CLI, 200 patients, the lesions were around 279. SFA target was 48%, but as it was multi-level disease, 17% specific to the popliteal and 34% in the infrapopliteal space. When you looked at the primary patency, and now this is segregated to both stenoses and occlusions, you can look at location by way of SFA, popliteal, and importantly, the infrapopliteal space, and the lesion lengths is tested. The SFA group and the CLI group was 8.6 centimeters, 5 centimeters in the popliteal, and then below that, 6 centimeters in the infrapopliteal space, with primary patencies of 70% and over 75% in the infrapopliteal space, which at the time was a remarkably high number for that group. If you look specifically at the CLI cohort, taking everybody else out, again, that's that 8.6, 5.4, and 6 centimeter lesion metric at 70% and 78%. All these things, when it comes to calcific disease, all come at a price. Whenever you manipulate an artery, there's always a risk of embolization. And directional atherectomy, which has been long maligned for having high numbers, this was analysis by patient. We did, at the time, the highest number of adjudications. Physician reported, CEC reported, and core lab adjudicated. If any of those three all aligned, then you had an event. If we didn't have an alignment with core lab, but the CEC reported it or the physician reported it, we counted that. And that's this total number of 7.6%. What's interesting is that distal embolization, which is the risk, distal protection, 25% of half of the number of these events had distal embolic protection in the cohort. Fast forward about 4 or 5 years, and now you have Viva Reality. This was about a 100-patient group that were screened, slow to enroll, but you can see the metrics of the patient population that was enrolled. The lesion length for heavily calcified and long. So both calcific and long lesions are what got you into reality. So the lesion length was about 18 centimeters, plus or minus about 8 centimeters. So it's a real lesion cohort. The diameter and CTO length was about 22, 23 centimeters. When it came to procedural complications, again, this was long and ugly, and so when it became long and ugly, the distal embolic rate went from 7.6 in definitive to 9.1, which required intervention. There's this little bit of a bastardization of how we look at distal embolization when it comes to these trials. That is, you can have a distal embolic event, but if you don't have to treat it, it doesn't get counted quite the same, which I find kind of ludicrous. But the overall embolic rates were 12.8%, so it's a real number in this trial. But when it came to patency, 22 centimeter CTOs, they were at 12 months, 84% primary patency, and 76, as you'll see here, on the end of the 12-month window out to that 22 centimeter CTO length and about 18 centimeter overall cohort. So this is a really remarkable trial that shows not only benefit of directional atherectomy and calcified lesions, but the marriage of directional atherectomy plus DCB is a remarkable outcome. Again, I don't really like CDTLR, although the FDA has kind of gravitated towards it, is that clinically driven TLR, which is a poor man's metric for restenosis. You can have an occluded artery, but you're still walking. That's still considered a success, and that's why these numbers are always positive. So 93% for CDTLR at the end of the 12-month window. PK out of Mount Sinai really showed, this was back in 2022, a meta-analysis, and everything that you're seeing, with very few exceptions, are registry data. And registries are really remarkably powerful data sets that tell you what the real world looks like. But to get into these registries, you always have to ask, what's the denominator? And if you don't know the denominator, then it falls back to what's called selection bias. And PK's group did a really good job here, and that's what this is trying to show you, is how you get into trials is half the battle. Who you study is remarkably important. And then for you to infer how you can treat your patients, that is something that is so inherently difficult to be able to tease away from trials and, more importantly, registries as to how you do real-world patients. And this, for directional atherectomy, shows you the bias to get into the trial, the confounding factors, and then all the other things that become important, how you did it at intervention, post-intervention, and so forth. And you can see here in the middle, Jim McKenzie, which led our trial for definitive, had moderate confounding bias for pre-intervention because you had to be eligible for the trial and not have a lot of calcium. And then you can see low risk for post-intervention and follow-up. And then you have a smattering of the other registries in that group. And again, characteristics of who got in, you can see low numbers, 21, all the way up to 1,200, or the 800 that we had in definitive. Excuse me. But if you look at primary and secondary patencies, across the board for all of these trials, you can see a fairly good outcome, many of which are not associated to DCB, but rather plain old balloon angioplasty. And then if you look specifically at CLI, open arteries save limbs, and this is amputation-free survival, salvage rates. This is always in the 90% range, and you can see here that almost exclusively they're in the 90% range. And the limb salvage rate in the SFA, popliteal and infrapopliteal, or multi-level disease shows benefit for the directional atherectomy combined with angioplasty to reestablish flow. So in short, if you look at directional atherectomy, it is turned into a fairly niche device today. I think that exophytic arteries that Peter was just describing when it comes to IVL may be a very useful thing for directional atherectomy. That control as opposed to orbiting may be helpful. This common femoral is really a fairly good place for directional atherectomy. And when it comes to the SFA disease, its combination with DCB, I think, because of reality, proves that it does work in in both, combining both therapies. More importantly, it leaves nothing behind, which is why I enjoy talking about it, but more importantly, use it, because I think it allows us to then come back for future failures of restenosis. I think when it comes to CLI patients, I think the benefit from adjunctive therapies for calcific lesions and longer lesions for wound healing are helpful, but there is no large-scale trial that has demonstrated primary benefit for any atherectomy device, quite frankly, when it comes to standalone or adjunctive treatment. Everybody has calcium, but if you're looking at the outcomes, short of life BTK, that is amputation-free survival, the combination has not benefited beyond angioplasty. And I think when it comes to directional atherectomy, careful and meticulous technique really allows for the best and most robust likelihood of successful clinical outcomes. Thank you for your attention.
Thanks, Mark. So for the sake of time, we'll keep one quick question here so we can continue. Given the, reality was complex lesion, to be sure. 13.8% distal embolization, even the other one is 3 or 4%. Are you, when you do directional atherectomy, are you using a protection system in basically all cases?
Yeah, I think 100% of the time we're using distal protection, particularly for almost always. Sometimes you can't get it down there for whatever reason back in the day, but right now we always use it. And the way that I always have segregated that answer is, it's always a challenge when you make a mistake and don't use it to then chase your rear end trying to fix it. So yeah, we use it as a preemptive strike.
Lawrence, one other quick question about reality. So that distal embolization rate of 12.8%, that was in spite of the fact that embolic protection was mandated?
In 100% of the cases, it was mandated.
That seems, quite high than what I think most of us are used to in our experience with directional atherectomy. Any speculation as to why it might have been as high as it was?
Yeah, so I fall back to definitive. Half of that group of definitive was driven by those who had distal protection. And so the issue is distal protection, I think, clearly will give you what you think you're going to get, right, Peter? At the end of the day, it gives you your ability to filter out the big stuff and even the small stuff, because it tumbles into these pore sizes. But when you look at it, getting it there, you're still embolizing. I think, our old colleague, Mike Woolley out of Texas, showed when he put distal protection down just for angioplasty, just for stenting, he captured debris. Not so much that it was any different. It was higher with atherectomy devices. But even with the simplest things, we still embolize. And so there's still, and particularly when it comes to these calcific things, you can always send off embolic debris. Moreover, short of the NAV6 today, but wire systems to not stay stationary is incredible. And the movement of those things will always create distal embolic events. And so I think that at the end of the day, I think you're right. It's a high number, but I think it's still part and parcel for what we're dealing with.
So question, now we have talked about 3 different atherectomies. For the audience, what's your algorithm? How do you choose which pathway you take if you have all of 3 available in your lab? This is because we're talking about different patient population, and
yeah.
What's your algorithm?
So this is an N of 1. Don't take this as gospel by any stretch. So the challenge I have is for most long lesions and diffuse calcific lesions, I've been a big jet stream proponent. And I think the jet stream, the reason for that is it aspirates. It's not a 1-to-1 aspiration. It's 80% to the 100% that you create. The challenge with CSI, although I think it's always been a very fluid device, and Peter trained me in that years ago, a little bit of powder is probably okay, but billions of particulates in a critically ischemic limb is probably not terribly useful. And so that's why I have gravitated away from that. I think directional has always been for those exophytic mountains that we deal with. And I think reality kind of proves that. As long as you can get your directional control correct, I think it works well. I didn't get a chance, and I don't know about the rest of the group, Phoenix and all these other devices which are out there, I think are still very useful, but that's kind of my algorithm in my brain.
So Lawrence, we know the directional atherectomy can have a higher rate of deeper cuts, deeper dissection. You've shown actually a case where you have a kind of a good pseudoaneurysm occurring, after a while. Bottom line is, are you using IVUS to determine these cases, and repair them as needed? Do you feel that leaving these deeper cuts without drug elution, drug modification, something that you're comfortable with. I personally IVIS these cases when I do them. If I see any type of deeper tear, I'm using either DCB or DES. And we know from PK's data, from Mount Sinai, that these patients, once you cut into the adventitia, restenosis rate is extremely high.
I think that's great, Nick, and you're right. For reality specifically, we were blinded to the IVIS. So it was a goal of oculostenotic outcomes of 30% or less, which was where definitive showed its benefit. But today, I think IVIS or some form of imaging is useful, particularly when you're going to go down the road of some drug elution, whatever that might be, because the risk of deep cuts, to your point, is the pseudoaneurysm. The positive remodeling you get with that from a deep cut is what we ended up with here. I think it's very useful for imaging.
Thanks, Lawrence.
All right, we're gonna move on. We're gonna introduce Zach Rosol to come up and talk to us about IVL, and hopefully we'll have an interesting case to discuss. Zach comes to us from Baylor Heart and Vascular in Plano.
Dallas. Partners.
Oh, Dallas, sorry.
Partners with
Dallas,
that.
Plano.
All good.
It's a Dallas
From
cowboy here. Watch it.
When you're in
All right,
Texas,
Zach.
we know it's
Zach from
the
Dallas,
Dallas
take it
area.
away.
It's Dallas or Plano. No, it's all good. We work together, Sameh and I as well. But I'm with Dr. Banerjee downtown. So we'll get started. I was tasked with talking about intravascular lithotripsy. So disclosures are listed online. So we're going to start with the first case here. So this is one of my patients who I've known well and worked on a lot, unfortunately, but the typical polyvascular disease patient who has every risk factor, including end-stage renal disease. He's got an ischemic cardiomyopathy despite having cabbage. He's had multiple bouts of critical limb ischemia bilaterally on his right leg. That's been treated with after unsuccessfully crossing his tibial vessels, he was treated with a popliteal to DP bypass, which allowed healing. We took the vein from his left leg to do that. And he's now back with his second bout of critical limb ischemia on his left leg again. We were able to balloon his perineal vessel in the past, which allowed healing. And here's what he's got calcific disease on his ABI and severely reduced TBI again with monophasic flow. So we'll look at his angiograms. He has very tortuous iliacs, and we know that there was no inflow disease before, so we went with an antegrade approach. And you can see here the typical diffuse, severe calcific disease with both positive and negative remodeling, okay? When you pass a microcatheter down, he's got a 120 millimeter gradient between his common femoral and his popliteal vessel, and severe calcific disease in the tibial vessels as well. And his really only runoff is his reconstitution of the DP. So here's the problem, right? We have deep nodular diffuse calcium. We have very little vessel elasticity and very poor runoff, which is going to be a setup for any stent thrombosis or no reflow issues as well, especially when we don't currently have inline flow all the way to the ankle. So this is where I think IVL is uniquely positioned to help mitigate some of these potential pitfalls and issues. So what do? We took a 6 millimeter M5, okay, and we did that up and down the vessel, moving. I did not use IVIS on this one. I know that's a topic of discussion. We had IVIS on previous interventions, and so we knew the size of the vessel at that point. So we deliver all 300 pulses. This is just post-shockwave proximally. We were able to cross into the perineal relatively easily again, and we used a chocolate balloon and a DCB, and here's our final conclusion. So these all gonna run, yep. So we now have inline flow back down to down to the ankle through the perineal. We've tried to cross this DP before antegrade, and we were unsuccessful. We used an aggressive wire and caused a perforation. And so this is just a couple weeks ago. So we're waiting to see, he just had debridement of his toe. We're waiting to see if this is gonna heal, and if not, he does not have another surgical option. So he's gonna have to be in bailout, try to go retrograde through his DP if needed. So, but we felt he healed before with this level of intervention, so we got him back to the same level that he had before in his prior interventions.
Zach, take us through your thought process. You obviously shockwave this. Did you try to get one vessel wired distally all the way down, or were you just trying to improve the pressure head into these collaterals?
Since I knew I had been down the perineal before, we got a wire all the way down into the perineal first, and then made our channel, and then came back and knew we needed to treat the inflow too. It wasn't enough in my mind when you had a 120 millimeter gradient between the common femoral and the popliteal to just treat a tibial vessel.
Zach, I'm sorry, could you just go back for a couple of slides here? Did you treat that popliteal disease, that P2 segment? Because on your final angiograms, it looks like there's still maybe some significant residual disease there in that pop right.
The P2
below,
segment, we didn't.
right below the-
We brought a 3.5 chocolate balloon up and around that, but that's where we left it.
Okay.
So, yep, I did not use further atherectomy at that point in time, knowing in short order I might be going back in for him. So, but this, knowing that we had poor runoff, it's a perineal vessel, we felt shockwave was our best option at this point in time for this gentleman. So I'll show case number 2. I think those are good points. And again, we can't get perfection, right? So what level is enough to say we should stop? And do you go all in on one? As the live case was showing us, do we treat to a certain level and then we reevaluate in a couple of weeks? Do we try to reconstruct an arch, as we were talking about, at all in one go? This point, we felt like reestablish where we knew he had healed before and then reevaluate shortly. Case number 2 here, this is another polyvascular disease patient with CKD4. His baseline creatinine's around 3. He's had prior cabbage. He now has Rutherford class 4 claudication. He's been doing at-home walking therapy with cilostazol in the past and is now failing all of that. He can only walk about 20 feet. He works as a maintenance operator, and so he can't really get around his apartment complex right now. His ABI is 0.5 at rest, and you can see the monophasic flow on the left. So here's a non-contrast CT scan that he has from about a year ago, and knowing that usually in an iliac case, I would do a CT scan to plan, but knowing with his renal dysfunction, we felt going in with an angiogram initially was the way to go. And that calcium measures about 7 millimeters in that area. So we went radial here, and you can see the near occlusive, arguably occlusive disease, but there's a trickle of antegrade flow here in that area. I'm not as big of a R2P as Sameh is, so we go retrograde here, and knowing that it was very calcific in case we needed a covered stent, that's why I decided to go retrograde. So we were actually able to cross pretty easily. Here's the IVUS. You can see heavy, dense, 360 degrees of calcium in this area. And old-fashioned way was to use brute force, do a bypass, or go cut it out, right? Well, the beauty now is with shockwave, I think this has really changed iliac interventions to make them much safer. So I did not pre-dilate. I was hoping with the way that I crossed with an 014 wire and a Navicross, an 035 Navicross. So I was hopeful with the Navicross going across, we'd be able to deliver the balloon. So we tried to go right in with a shockwave L6, and this is a 10 by 30. And that was able to cross right away just on the fluoro store there. That's why I saved that. So we did all 300 pulses. You can see it started with the typical dog bone, but as we went along, we had a significant improvement with delivering all those pulses. And then this is our final result after placing an uncovered stent. Let's see the angios. Well, those are just still shots, but you can see the 360 degrees of calcium. We have great stent expansion, and that measures about 9 millimeters.
Zach, which shockwave was that?
That was the L6, 10 by 30.
10 by 30, okay.
Yep, 10 by 30. So what are my tips and tricks and my thoughts if I'm going to use shockwave? You have to size appropriately. You can't be afraid to undersize this like we do sometimes when we pre-dilate. The whole purpose and the whole mechanism of action is to have apposition to the wall. And you want to make sure you're removing all of the air from this balloon because this is high pressure ultrasound waves, and so those travel better through fluid, and you want the balloon to touch the size of the vessel, okay? And so that's why oversizing is actually probably better. The other thing is you don't want to overinflate this balloon when you're treating, okay? Because if you overinflate the balloon, it's a compliant balloon. You are stretching out the vessel further, which takes the emitters further from the calcium, okay? So then the sound waves have to travel further, and they're not as effective then. So the whole goal of this, you can shockwave at 1, 2, 3, 4 atmospheres. Nominal pressure is 6 millimeters on these balloons, but you don't want to shockwave at 6 millimeters because it pushes the emitters further away from the vessel wall surface, okay? You can use it in the subintimal space if you have to. you're getting the device out, so you use the whole device, okay? Don't just use 40 impulses after one treatment because you think it looks better. The more you can cause microfractures throughout this calcium, the better vessel compliance you're going to have as a whole. The other thing is that the way the vessels are, the way the emitters are designed, they do send out these high frequency pulse waves, and the goal is for them to overlap, but that's not perfect. So it's not good enough to just inflate, deflate, and keep going in the same area. You've got to get in the habit of moving the balloon by a few millimeters each time to allow the best, in order to treat the entire vessel area. I think one of the pitfalls of this still is that it's over an 014 wire. So when we're talking about in the peripheral space through very calcified vessels, sometimes that can make it hard to deliver. So try to use a supportive wire if you can in order to deliver that.
It just bears mentioning, though, that the larger devices, the L6 devices, do go over an 018 wire.
Yes, that's true.
And especially for these larger devices like the iliacs and the aorta, it is nice to have that more supportive wire.
Right. The M devices and the S are still 014.
And I always like to tell people when they ask me about IVL, I'm like, why wouldn't you use all the pulses? You wouldn't leave half a beer, would you? You'd finish your beer before you go home, so why not finish the job here and use all 300 pulses?
So
question to the panel. I mean, Shockwave has been the leading force in IVL because the first company that came to the market, and I think how easy to use and how, from a PAD 3, and even from the coronary perspective, the CAD3 trial, the disembolization, the complication rate is very low. Now we have, 5 different startup company coming out in the next 5 years with IVL. What do you guys think is going to be, what are those companies going to offer us that we do not have today? And what you're looking for in those products that's going to be able to compete with IVL? Because is IVL, or is it the technology? Is it the length? Is it crossability?
I think there are a lot of new players coming out, and let me say I have a conflict in the national PI for one that's starting. Nick may be our first operator, we'll see, but AVS, it's really a novel development, and it still combines the simplicity of the Shockwave IVL with a small console that was well wheeled in, push a button, and a balloon. Others are trying to get in. I think they've seen the sticker price that J&J paid for Shockwave, and everybody's now rushing to the line as quick as they can. Some of them are calling themselves IVL when they're really scoring balloons, and contact devices, kind of similar to the crosser. I think we have to keep our eye on the science. There are trials coming out that we'll watch. I look forward to maybe even coming out to Davenport and seeing the first case if Nick gets things ready. But you're right, there's a lot of players. I think we keep our eye on the science behind them. And I think as we do, we'll see some, even new expansions of it. I will say I didn't believe Shockwave was going to be good. I was dead wrong. I love the technology now, IVL, and it will probably only get better with experience.
I think that things can be improved upon, right? So, Sameh, I think that the mechanism of action of Shockwave with the wave, and with these other devices, Bolt and FastWave and AVS, the mechanisms are slightly different, or some are significantly different, which means that the outcomes may also be more advantageous in certain situations. And if the matrix of balloons that we get are particularly different, longer, and the ability to really treat this nodular calcium. So there will be some differentiation between these devices, mainly because they don't all work the same. So the trials will help us figure that out. I think there's going to be room for way more than one, probably more than two, potentially more than three in this space, because we're finding new places to use it every day. Not the least of which is now more superior in the circulation, like carotids are a conversation for IVL now, which I never thought would be an issue. So I think that there's going to be a lot of room for these devices. And also, we talked so much about atherectomy, and people that are comfortable with atherectomy use it on a regular basis, but it's not going to be it'll be easier to adopt IVL, and it's already been proven to be easier to adopt for every operator, as opposed to those
I think from an industry perspective, that's huge, because this applies to your average operator. Right. You don't have to have all the fancy extra equipment, the fears of the perforations and the distal embolization. You don't have to use distal embolic protection. It's a balloon with a button. Some of them are a little complicated. They'll put laser together with this. Maybe that may not be in your category, but Lawrence will.
Yeah, I was simply going to say that I think the point is, it's actually the most important point of all of these talks is that IVL now has supplanted almost exclusively our atherectomy in many ways. The idea of having to do some form of debulking, which is our focus for so many years, has now been supplanted by IVL. And whether or not it's a one and done for just shockwave and it goes into these other modalities or these other types of IVL, the critical part is it really is the discussion today when it comes to lower extremity revascularization that I find very useful, because to your point, it now becomes simpler because the operation is back to a simple balloon. It's very simple to comprehend.
We have to remember that there are devices that can do what IVL do, like laser. We already have data to show from cadaveric, models, using, for instance, the laser created microfracture in the calcium, even the deeper calcium. So I don't know how that would compare with IVL down the road. If you use the laser only and create all these microfractures in the calcium, how would that compare to all the concept, of dedicated lithotripsy device? So I'd be curious to see if anybody has any comments on this.
Do you guys feel that just vessel expansion, because arguably IVL leads to better vessel expansion, but we're not necessarily disrupting media or the intima as well. So thoughts on atherectomy leading to better outcomes with atherectomy plus DCB versus just better vessel expansion with DCB? We know we all have micro dissections everywhere when we balloon anything in intimal injury, but do you think you're getting a better drug effect with atherectomy or not?
Zach, when do you quit using IVL? Do you ever have a good result or some result and then need to pull out another balloon? Are you limited with this 300 pulses or whatever the maximum number of pulses is on the balloon you're using?
To take out multiple IVLs? Is that what you're saying?
Yeah. There are times where I've thought, especially in these big iliacs where you have a lot of calcium, you start to get some effect and then you sort of burn out the balloon. Do you ever come back and treat it twice?
I think the difference is before.
Can you overdose?
I don't think you can overdose, but I don't know if you're gaining extra effect in that. I think you have to watch what's happening with your expansion, so that's why I showed those different pictures. Clearly it wasn't enough initially. Now, sometimes it's a matter of deliverability too. So with the M5 Plus or the longer balloons that were sometimes more difficult to deliver, the nice part about the L category balloons is that you've got all those emitters that are focused now over 30 millimeters, so you're having, especially for the calcific disease and the iliacs and common iliacs, you're arguably getting a greater treatment effect over a smaller space, which is hopefully more effective rather than having to, where all the emitters were separated by like 8 millimeters before, you were having to move the balloon a lot, and you maybe weren't getting as much concentrated effect in that regard. So have I used 2 balloons in the past? Yes. Especially with the iliacs, I think the L6 helps a lot in that regard to just focus the treatment zone.
So, Drew, we're going to go to you next because our host, Subhash, is just a gentleman from the South, and he wants to make sure you get in, and then he'll keep himself to the end. So, Zach, obviously, generated a lot of good discussion there, so thank you very much. And Drew's going to talk to us about specialty balloons. We've heard a little bit about and seen some of the sessions, and Drew's going to share a case with us regarding that.
Yeah, I get the good morning, everyone. I get the kind of boring topic, specialty balloons. But I guess the question is it a balloon? Is it just a balloon? Or is there maybe perhaps a little bit more? And I'm not going to talk about IVL. We just heard about that. I'm not going to talk about DCB. There's a whole other section later. But let's go forward. Let's see what we got. What just happened there? You guys get my stuff back up? Perfect. All right. So I have no disclosures, by the way, other than I love my job, and I'm an internist, cardiologist, a vascular interventional specialist. However, I have to say that I am an interventional cardiologist, and if you guys don't know this slide, Herms came up with this and gave it to Chris White. This is what our brain looks like for those of you who are interventional cardiologists. And so we do have an oculus stenotic stenting and dilatation center, and it's quite large and a very small, intelligent thought and evidence-based medicine, at least many times in the periphery at least. And so with that, we're going to talk about objectives. So our goal with balloons is what? We have to vessel prep. We got to make certain that that's obvious, right? We need to do, just like Zach showed, really good vessel prep, or else your stent is not going to work. And sometimes we only have balloons alone, so do it right, okay? So for those of you who don't remember, and Lawrence, I'm there with you, I'm starting to feel real old. The original balloon angioplasty was Charlie Dotter, and hence the term Charlie Dottering, using a series of crude catheters to basically push through a stenosis at the SFA, at the adductor aortus, and essentially took a lady with critical limb ischemia and was able to lead to, from what was to be a below in the knee amputation to just toe amputations. And she died 3 years later from actually congestive heart failure. So here's the case. It's your usual train wreck, like all of us have. It's a 72-year-old male with a non-healing ulcer, long-standing diabetes. I'm not going to give you guys the details of the toe pressures were terrible. This guy was terrible. Of course, his wife is one of our nurses who worked for my partner. So, of course, I said, sir, we got to get this taken care of. He's like, I'm going on vacation. And I came back, and now his toe was necrotic with dry ester, and we knew we were going to be in a problem. So it was the fifth toe, it was in the PT angiosome, and so we went straight to angio based on our non-invasive studies. And this is what we got. So usual crossover plan here. I did not have a CT angiogram beforehand. Just trust me that everything up above looked pretty good. Minus the SFA, you can see a focal lesion down at the adductor aortus, and then below the knee he has nothing, except we have reconstitution of the posterior tibial, a little bit of DP there from what I could see. And so what we did was basically crossover with a 690 sheath, quick cross, got through the TPT with a 018 wire. I stuck 018 style, just which is a little bit unique. Usually I go 0.014, and then I was able to get into the posterior tibial artery using a V18 wire. And then here I used an apex balloon, so using a lot of coronary balloons here more than anything because we're up and over. I agree with you, Tony. I like doing up and over just from the bleeding complication issue. This guy is also not that tall, which helped me do this versus going crossover or going anterograde. And then we treated with a chocolate balloon, 4x40. We actually did IVUS as well to make certain that we're really sizing. And I think the emphasis here is more than anything, if you look at some of the new data out there, is that I wouldn't do a coronary stent without IVUS. This is coronary vascular size. When are we going to stop thinking we know what size this is and just start using IVUS? I think we're going to get there. I think 5 years from now it's going to be standard of care. So IVUS here did a chocolate balloon in the PT, and then I actually ended up having a bad dissection and put a Synergy stent there, which we post-dilated to 4 millimeters. So this is just where we run off at the end. We actually went down and used a nanocross. If you're not using these, you must be under a rock. But the tapered balloons, I think, are specialty balloons as well. So you can go from a 3.0 to a 2.5. I probably undersized this. I probably should have gone a little bit bigger. That's using nanocross. And the distal PT, I went down with a 2.5. And then the SFA, we actually just treated with a 120 millimeter chocolate balloon and then used a Ranger DCB. At the end of the day here, that's what that looked like too, before and after. Patient went on for a limited amp of the 5th digit, and we actually followed him. His wound healed, and then of course his other foot got a problem. Then we went over and did the other side. Then we went back and did the other side when he had another problem a little bit later. So we follow this guy, and I think we all should follow patients till the wounds heal. We know there's going to be restenosis. We know there's going to be at some point where it's going to re-narrow again, or till you hit a plateau. So I basically follow, and I'm sure all of you do, follow these patients carefully, work closely with your wound care center, and really it's about if the wound's healed and it re-narrows, I'm okay with that. If the wound plateaus, we got to go back in. I'm going to pause right here and ask the panel if they have any questions or any feedback on things. Chris, what do you think? I mean, it's a relatively straightforward CLI case, straightforward balloons, one stent, out of Dodge. Anything in particular you would have done differently, orbital atherectomy or anything? Or anyone?
Thoughts? I think you did the right thing. Thoughts?
I have a question.
Yeah, Subhash has the question.
I have a question. So when you do this, you talked about imaging.
Mm-hmm.
So I think it is important to use imaging maybe not just at the front end, but also to assess periodic changes in strategy? Because I think that's an important question. So I don't want to make this, that is why I was asking those questions about the OCT, because that's harder to do.
Exactly,
Like,
exactly.
IVUS is very, very easy to do.
It's very easy to do. So Dr. Banerjee's question is, should you be using it throughout the procedure, not just on the front and the back end? And I think that's a good question. Like, are you getting the expansion you need with these balloons? Are you getting the good stent expansion if you're putting in stents? I think it's important, just like we would in the coronary literature, we would say that we should do this. And I think the day will come where we'll be using this on a regular basis. So just to go through the balloons that are out there, the chocolate balloon, who doesn't love chocolate? It's my favorite balloon, actually. It killed me that they pulled it off in the coronary world. But the so-called pillows of air, I have to say, I used to think this was BS when it first came out, but I've been very impressed, and I love using it on a regular basis for limited balloon angioplasty only. There's the tapered nanocross balloon, nano, as I usually say. None of my millennials in the lab know exactly what I'm talking about. I'm hoping some Gen X people know what I'm talking about here. So nano for Rob Williams. If you don't know what this is, talk to me later about it, please. Wolverine cutting balloon. So Wolverine or any of the traditional cutting balloon, I don't like the profile on this as much. Sometimes can be very hard to get through, but very effective, especially for calcium with the microtomes. I mean, and then the Scoreflex balloon, I didn't really have any good funny pictures for this, but the Scoreflex is essentially like a poor man's wire down alongside with a balloon, a non-compliant balloon, at least to me. And one of my partners loves this balloon. I'm just not a huge fan of it, but that's another option for people. It's got a really short RX onto it. And then of course the OPM balloon, the new kid on the block, if you will. This is a high pressure balloon that can go up to 35 atmospheres. This is not approved for the periphery, I believe. I believe it's only coronary, but of course, we're used to using things off label. So you can use this down if need be. Just be careful, it is 35 atmospheres of pressure. And so I think balloons are the OG of this treatment, right? Like, I don't know if I would have done this back in the old days of using 20 millimeter coronary balloons up and down the whole S of A or whatever they were doing back then. We use balloons for vessel prep. I think the key for this is really using long inflations. I do 2-3 minute inflations at a time, really using Ivan's guidance, and then I jump in a whole bunch of vasodilators. And I think it's important because if you do that, you're gonna get better pictures, you're gonna get good IVUS guidance one-to-one in terms of getting a good balloon size, and hopefully at the end of the day, you're gonna get a good result. Just a word, by the way, please get the word out. This is CLTI about Pulse PAD, about how we have major disparities of care. I'm preaching to the choir here. We really need to make sure that we take care of all of our patients, especially those that are underserved and underrepresented in our trials. Thank you very much.
Drew, thanks very much. I would feel remiss if we didn't at least mention one of the other scoring balloons on the market is the Serenator from Cajun Vascular, and that is a device which comes in 40 and 120 millimeter lengths. They're going to be coming out with a 6 millimeter diameter device very soon with a limited market release. So thanks very much for that overview. And we're going to bring our esteemed colleague and fearless leader, Dr. Banerjee, up to give us one last case presentation.
Well, thank you very much. I'll be very brief because the discussion has been very enlightening. I would start by saying that in the coronary world, there can be CTO and non-CTO operators. Given the frequency of chronic total occlusions, which can be as high as 38 to 40%, it is nearly obligatory for a CTO operator in the peripheral arteries to be able to deal and know how to tackle CTOs. That's number one. And the second big message I want to share, that the strategy to cross a chronic total occlusion should be done with the final treatment in mind, because it heavily impacts how the final treatment will be. And as we go along, I will share a very fairly simple case. This is a claudicant. I'm going to spare you all the clinical scenario and take a few moments to look at this angiogram. It can be a very simple case, and it can be a very long day. And I think one of the most important decisions in tackling a chronic total occlusion with a device or a guide wire approach is to decide on the first initial crossing approach. I think that is the rate limiting step, how this case will progress. So I wanted to put a Microsoft poll and I couldn't for technical reasons, but except for the audience, except for the panelists, anyone in the audience, anyone who would primarily approach it retrograde from the pedal. I have shown you the pedal angiograms. Any takers? Drew, don't be shy. And you, Dr. Mixon, will go retrograde primarily. Anyone who would try to use a penetrating wire or XTTO crossing device, antegrade, or call Dr. Ait in service to do the honors. So I think about it, and let me show you what we did, and I will try to share which one, in my opinion, is a simple but an important step in tackling this lesion. So this was a relatively good day. So the first step in our procedure was an intravascular ultrasound to know precisely where the proximal cap is. Because even if you come retrograde, and this is just logic, and feel free to disagree, and I'll just share one case for the sake of discussion. Even if you come retrograde, it would be not easy to create a rendezvous in the middle of the SFA and at the same time not destroy this large collateral. And this case could be quite a difficult one. So please stop and chime in if there are other dissenting opinions. The second very important step in my view is that as you make the first pass with the guide wire and you have a relatively good feeling, but you are not sure you are intimal or subintimal after you know where the proximal cap is with intravascular ultrasound, is, in my opinion, is to occupy that space with a catheter. So one of the challenges of enduring through a guide wire approach is to keep making passages with the guide wire, having the subintimal plane, if you happen to be there, compressed with the antegrade flow of blood that falls into the channel, that takes you away from the true lumen and also can cause compression of the collateral. So one important step between image number 2 to image number 3 is to actually occupy that space. And if you do that, you will have, while you are going downwards trying to enter the true lumen, you will probably not extend the subintimal or the dissection plane or not cause a large enough intramural hematoma. And this principle, in my humble opinion, would be useful to follow. So the case went that the guide wire actually did not travel into the true lumen, and with some very simple stiffer guide wire, we were able to do something called limited antegrade dissection and thread the guide wire into the true lumen. And if you look at the intravascular ultrasound of this case, it is very revealing. Don't pay attention to the lumen, but pay attention to the dark band that is around the lumen, which is the media. And as long as you have created a dissection plane, or even if it is limited dissection like here, but it is contained within the media, you are likely be able to treat that with a non-stent approach. So I think thinking about how to cross a chronic total occlusion and thinking about the first movements are going to be critical. Now, these are two nearly identical cases, Chris. So one is with a crossing device and one is with a guide wire. But in both those cases, the initial approach was done. There are two different patients with intravascular ultrasound localizing the proximal cap, and then occupying the first penetrating action. So even if you went subintimal and you advanced an 035 catheter into the space, you can then come retrograde and re-enter. And the criteria that would be most important is that if you don't extend that dissection plane beyond the size you need to know. So I'm going to skip through this and not show this, this grand scheme, but the two principles are, when you think about switching approaches, are you doing it because the first approach has failed, or it is more efficient to use the second approach, retrograde, but not giving up the primary approach? So the key approach is, in my mind, is rendezvous. I really decide in my mind where I would connect the two retrograde and antegrade wires. And second is that if I'm unsuccessful, what is the interoperability of switching between strategies? And in my opinion, it heavily and entirely is dependent on the degree of subintimal dissection plane and or the intramural hematoma one has created. So I want to show you one last case. This was a long calcified chronic total occlusion, and this is where real happiness strikes the operator. Okay, and you feel very good. And then with laser, you create a channel. But I want to show you one step before this. So look what actually happened. Every time we made advances with the guide wire, we got the catheter to occupy that space and never make a loop. So both retrograde and antegrade, there's a retrograde catheter at the bottom of the screen and an antegrade catheter. And I have humbly suggest that newer operators who are trying to deal with chronic total occlusions, I think you will have a less frustrating and more reproducible success if you adopt this simple strategy of not letting the intramural space grow. So here is, in brief, the overall approach of a rendezvous strategy. That you do targeted advancement of an antegrade guide wire. If you happen to cause a limited subintimal dissection, then prevent recoil of the subintimal space or filling it up with blood by placing a receiving catheter. And you will then place yourself in the best position to come retrograde and create a rendezvous and yet not give up that option. So I actually consider even catheters as CTO crossing devices. And by keeping the dissection plane very limited, your options of re-entry are greatly enhanced, and you can create limited amount of dissections. And finally, you can use non-stent based treatments for femoral and even in the below the knee. Now, there is a role for directional control of occlusion devices, and I've shown you these are some of the areas of using the Vian's catheter. But last point is, everyone talks about these animations. And look what these animations are really doing. They are showing directional tip control, finding the right spot to enter the chronic total occlusion, and then create a channel through the plaque by causing compression of the plaque. So do these current devices really offer this kind of control, or the animation does justice to how this device truly operates? So I think the next generation CTO crossing devices, apart from being lower profile, need to have directional tip control, a centering mechanism, and then be able to cause some plaque compression that would create a channel that you can re-enter and advance a catheter through it so you can create a successful rendezvous. This is our data from one of the largest observational consecutive 22 center CTOs in femoral-popliteal area, 1,345 chronic total occlusions, 18% use of crossing devices. But look what happens when you start with a guide wire. In about 15%, you still end up using a crossing device or a re-entry device, and your overall technical success adjudicated by the core laboratory is actually higher, although the procedural success is equal with both the devices. An issue about cost. There is about a 13% greater use of longer stents. The overall stent length with guide wire approach was much longer, and here is an arithmetic dollar and cents equation that you will end up using nearly $423.80 more in about 1,000 procedures if you cause dissection and use stents versus you use a crossing device. And I'm not saying that is a rationale to do this, but the exaggerated cost of a crossing device or a re-entry device, if you create a very limited dissection plane, can be quite controlled. So my take-home messages, in brief, careful examination and analysis of the diagnostic angiogram. Second, tip control, centering, and plaque compression is going to be the forte for the next generation chronic total devices, and of course have expertise, like all the speakers have said, with one or two more procedures. And think about CTO ergonomics. That's the word I want to introduce, is think about how are you going to make the first approach, and how is it going to set you up if that approach is not successful. And I think that is what I want to share. And of course, share the wonderful registry team that I have assembled. And these gentlemen and ladies keep the data coming. And I encourage you to send your data to me. I will be happy to analyze. Thank you very much.
Thanks, Subhash. A couple things that you showed so eloquently. You don't want to extend the dissection, you want to meet in the middle. And you showed a couple things that were on there. Every case you did had a piece of ruler tape on there. So you know I'm not going beyond 23 because that's where the reentry point was. And either roadmap or angiogram. So once you get there and you can't get there, don't keep pushing and go retrograde and meet in the middle, not beyond.
Well, you touched a chord, because in our instructions, the use of a ruler and the use of fluoroscopy and not injecting contrast. That is why OCT is a little harder. Even if you are not injecting into the lesion, if you stain it, your day is done. I used to do live cases when Tony used to operate, I used to moderate, and he used to say repeatedly, if you cause a stain in the subintimal space, your day is going to be a very long and bad day. So thanks for emphasizing that. Yes, Dr. Ait.
I guess yeah, there we go. So the question I have is, by using the rendezvous technique, you believe that you're going to have a lower need for stenting than you would if you just used an antegrade re-entry device.
That's the concept.
Yeah. And is
That's
that
the concept.
proven?
Well, proven in observational studies, but not proven in randomized. But if you guys have the energy and the zeal, I'll be happy to randomize each of your patients. But go ahead, Dr. Garcia.
No, I was simply going to say the Japanese have been doing rendezvous for eons now, and their data for lack of stenting is quite high. So there is something to be said for that. And they, you know, my good friend who's now semi-retired is Yoshi Okoye, and he used to say in every Japanese meeting I was at, do the dutiful but unnecessary IVUS, Japanese IVUS. And he's been proven so wrong in the fact that IVUS is so useful in what we do today. And I think in the rendezvous technique, staying true luminal has benefited the patients. I would just recommend looking at that data.
Because the option it opens up both for atherectomy, IVL, and other, the expanse of options available to the operator are greatly enhanced. And I think that is why frequent imaging during the case and not extended dissection plane are the two, I think, simple principles.
I think the cases you showed also showed the importance for operator to be comfortable also with pedal access.
Yes.
I think a lot of operators don't go to the pedal access till it's the last resort, and I think that's how. I mean, as someone with the panel said, usually try with the easier case first to learn. I think being very comfortable with pedal access in those cases can be very helpful.
I have a very subtle example how to plan for pedal access. It's a longer answer, but is to ultrasound the pedal arteries before the patient gets on the table. The advantage of that is that the team and everyone is prepared. It is not imaging the artery, but putting in everyone's mind that this is something you've contemplated and not doing ad hoc. I think that is the thing, and how you set up the room, the ergonomics comes into play. So these are profoundly deep questions, which I think we will have to discuss at other points, but I appreciate very much for the opportunity.
Fantastic point. Well, I think with this, we're about at the end of the session here. We've got a lunch symposium.